personally don't do procedures. It was something that I decided a long time ago wasn't what floated my boat. However, I will tell you that a lot of heart failure practitioners do procedures. They do many procedures. They do a lot of their own right heart catheterizations.
Hello, hello, hello. Welcome to eShadowing. Welcome, welcome, welcome. I'm excited for all of you to be here. We have an amazing guest, Dr. Michelle Bloom. If I can find her on this crazy expanding list. Dr. Bloom, if you are there, can you raise your hand in Zoom and we'll get you on? Oh, I see you. Now I just got to get you. Oh, let me see. Oh, I missed you. Hello, Diana. This fun game that we have to play at the beginning is crazy. Dr. Bloom, I just promoted you to panelist. Oh, and you declined. Let's get you one more time so we can get you. All right. We got her, folks. Dr. Bloom in the house. Hello there.
Oh my gosh, that was scarier than taking care of a person in cardiogenic shock.
We did it.
My gosh.
It's funny what we as physicians like deem scary and crazy. Like
that was very stressful. I was like, why isn't he picking up? Did I get the time wrong, the day wrong?
We're here. Nobody's decompensating. No crash carts needed. We made it. Thank you for joining me. Oh, that's so funny. We're going to talk about some fun little subspecialty, little niche in the world. Yeah. Heart failure, advanced heart failure, not no basic heart failure,
right? Advanced
heart failure, and this cardio-oncology.
Yes.
I don't know if I've ever heard this combination of specialties before, so I'm super interested to learn how you ended up here.
Yeah,
it's a very easy question.
It's a very easy question. So first, I'm just going to tell you, Ryan, this is real life. So I'm doing this from home, and my 8-year-old just came home from school.
I love it.
He's been told not to interrupt, but if you hear a little person, that's why.
No worries.
This is real life.
I have done many e-shadowings. I used to do them at night. And my wife, also a physician, would come home late sometimes, as doctors do. And I would leave my 8 and 4-year-old upstairs, and I'd be like, you be quiet. And sometimes I would tell the guests, if my kids yell, I'm going to run away. And I did that a few times. And then you know what? We just
I do think this has become normalized in the era of the pandemic and Zoom, but still, nonetheless, I always feel like I should give a disclaimer, and the dogs. But anyway, so cardio-oncology. So as I told you guys, when you invited me, which thank you so much for inviting me, this is actually the most exciting thing I'll do all month. I'm actually an advanced heart failure cardiologist. So I did medicine, internal medicine, then I did cardiology. Then I actually did an extra year of advanced heart failure, where I also became board certified in mechanical circulatory support, like left ventricular assist devices, but also heart transplant. And then the cardio-oncology thing actually came later. So I actually put this up because, when you think about this, you realize how much training you had to get to be where you are. It's actually insane.
That whole 1-2 skip a few, it's a lie.
Yeah, it's a total farce. So I did obviously 4 years of high school. I grew up in New Jersey. I did 4 years of undergraduate at Brandeis in Massachusetts near Boston. I did 4 years of medical school. Then I went on to do internal medicine residency, as most subspecialists do to pick a subspecialty in medicine. I actually took a small hiatus for a year to do a clinical research fellowship at Columbia, and then went back to do the rest of my internal medicine training at Montefiore in the Bronx in New York.
Yeah.
And then I did a cardiology fellowship at Mount Sinai in New York, became board certified in cardiology, stayed at Mount Sinai because I was so happy there and I loved it there to do heart failure and transplant. And then I didn't do cardio-onc yet. I actually started my first attending job at Stony Brook, which is where I have been ever since. And I started in 2011. So I've been there for about 12 years. Mm-hmm. And the cardio-oncology thing didn't happen until several years later. But it's interesting because, so first, to even take a step back. So what is cardio-oncology? Cardio-oncology, I always tell my patients, it's like the marriage of cardiology and oncology. It's like if a cardiologist married an oncologist, what would they talk about at the dinner table? Oh, and I also put this in here. You can scroll through because by the way, as a separate side note, Ryan, and I don't know if your other guests talk about this, but I mentor a lot of people in medicine.
Yeah.
And I feel like this stuff is just as important as the medical stuff because
1,000%.
people are like, when did you have 3 kids?
Yeah.
When did you have time to get married? And I feel like it's important, the life-work balance.
Nobody talks about it.
Nobody talks about it, but I talk about it because I feel like it's so, so, so important. So I put that in because when I mentor particularly female students and residents, they want to know, like, how are they supposed to do the rest of their life?
Yeah.
But anyway,
it's an easy answer. Whenever you want.
Whenever you can, because there's no right time.
Exactly.
But anyway, so it's like if a cardiologist married an oncologist, what would they talk about at the dinner table? Because what it is that obviously oncology is a very, very, broad field in and of itself, but either people with cancer start out getting their cancer diagnosis already with cardiac disease. So maybe they're a person who had a history of heart failure. They had a history of a bypass surgery. They had a history of congenital heart disease or 1,000 different things. Yeah. Or a person never had a cardiac issue in their life. And then all of a sudden, boom, they get a diagnosis of cancer. And then they have to get, some type of chemotherapy or radiation or some type of surgery or whatever. And that can actually lead to cardiac disease. And then there's a whole other subset of people that we take care of in cardio-oncology who are survivors of childhood cancer. So let's say, God forbid, a kid gets a malignancy and they have to get chemotherapy when they're little. And then all of a sudden, their cancer is cured and they go on to, lead a productive life. And then all of a sudden in their 20s or 30s or 40s or 50s, they develop cardiac disease. And if you look back, you realize it's because of whatever they got for their cancer that predisposed them. So there's a whole huge gamut of patients that fall into this big umbrella of cardio-oncology, which is kind of why I love it, because it's not just one, subset of patients, but it's a whole gamut of patients that would benefit from the expertise of someone who had a background in the combination.
Yeah. So let me see if I understand this correctly. As a cardio-oncologist, you're doing less oncology, but more of the heart failure and other cardiac complications that come with patients who do have cancer or the kind of ramifications of their cancer therapy and are hopefully doing better now.
That's 100% right. I mean, I'm not an oncologist. The only oncology that I knew prior to becoming a cardio-oncologist was what I learned as an internal medicine resident. And actually I co-founded the cardio-oncology program with a breast oncologist, because really, in order, I think, to be successful in even building a program, which we could talk about if you want later, you really need buy-in from the oncologist to appreciate that this is a thing. Otherwise, if you don't have oncologists who buy into the fact that you need a cardiologist involved in their patient's care, you're kind of done, because then you don't even get fed any patients. So my whole referral base as a cardiologist is from oncology, but I am doing, anything and everything having to do with their cardiac care.
Yeah, because typically patients who do have cancer, undergoing chemotherapy, all that fun stuff, not fun stuff, their oncologist is their primary care provider at that point, right? And so they are the ones that are referring out to different subspecialties when needed. And if they don't know about you, then they won't refer to you, because
That's right.
The similar saying for medical school, like if you've never seen it, you can't diagnose it.
That's right.
And so that's interesting. So I want to talk about, and I'm kind of short circuiting maybe the talk, because you were like, well, we can talk about founding something like cardio-oncology. How common is it? How many of them of you are out there?
Yeah, I actually don't know the answer to that question. I can tell you that it's a way more common now than it was when I was doing my training. And I'll tell you that because there was no such thing as a cardio-oncology training program when I was training, whatever it was, 15 years ago. Now, a person actually can do formal training in cardio-oncology. I actually self-trained. I taught myself. I went to a ton of conferences. I kind of began my exploration when I was a cardiology fellow because I just saw a bunch of those patients. And I just began to love seeing those patients and saw in myself my trend toward loving that. But I am mostly self-taught. But now a person could do either a cardio-oncology year or two before they do a cardiology fellowship, or they actually can do it after. And in fact, I'm really excited because last week we hired a while ago, but last week she started a second cardio-oncologist who's way junior to me, but actually just spent 2 years at Sloan Kettering Cancer Center in the city after a heart failure and cardiology fellowship. So she actually got formal training in cardio-oncology. So it's in answer to your question, it's way more common now than it was a few years ago. And as the years go on, it's becoming more and more established and more recognized as a specialty, but it's relatively new compared with other, cardiac subspecialties for sure.
So I'll add, maybe this is a dumb question. We know that theoretically patients have always had hearts. Cancer has been around for a long time. Why is this such a new and budding subspecialty? Are chemotherapies? I thought the chemotherapies were getting better and more targeted.
Yeah.
Are they getting worse for the hearts? Are patients just living longer because we are getting better with cancer therapies, and so then they need you more? What's going on there that we need more of you?
I think it's actually all of the above. I think you hit many of your points are well taken. And I think it's really all of it. Number one, we know that cancer and cardiac disease are increasing in frequency as people live to older years, right? So, people used to die a lot younger. They didn't live to see cardiac disease or live to see multiple cancers. Now they do, because we're much better at, general and preventative care. Second, I think, it used to be just that there were a couple different cancer therapies that we primarily used that we knew were sort of like the classic causes of cardiac toxicity. Now, cancer therapy has blown up to the point where every week the FDA is approving a new cancer therapy. Even as a cardio-oncologist, I will tell you that very often a patient will come into the office and I have to look up what they're on because it was approved a week ago. I'm not even being facetious when I say it. I think oncology is one of those fields where it is so rapidly expanding that it's impossible to keep up. Yeah. And a lot of the newer oncology therapies actually do have untoward consequences toward the heart. So for example, there's these therapies called immune checkpoint inhibitors, which patients essentially, like, you have cancer and your oncologist is going to use an immune checkpoint inhibitor. What it does is it actually stops the immune system in its tracks, because we know obviously the immune system can attack and proliferate cancer cells. Mm-hmm. So the issue is that even when they become more and more targeted, there can be untoward consequences where they accidentally target the heart. And so while these have totally changed the face of cancer therapy, like people that were dying of metastatic melanoma, for example, are now living years and years and years because they're on these therapies. The problem is that sort of the double-edged sword of it is that they can actually develop cardiac toxicity from it.
Yeah, got it. Okay, that makes a lot of sense. So what does a day in the life of your job look like?
Well, today I'm actually home because I just finished 7 days on call in the hospital. But a day in the life usually depends on the week and it depends on the day. So I do both. I do advanced heart failure, but I also do cardio-oncology. Like in the office, like in my office day, I actually combine the two. So I can walk in the morning, I see new patients, and some of them are newly diagnosed cancer patients who, need me to take a look at their situation to sort of prime them for safe administration of cancer therapy. So cardio-oncology cases. And then some of them may actually be advanced heart failure patients who need evaluation, for example, for a mechanical pump like an LVAD or a transplant. So it's a totally mixed bag. In the morning in the office, I see new patients. Then I go straight into the afternoon where I'm seeing a lot of my follow-up patients. That's my day in the office. If I'm in the hospital, like I just finished a week in the hospital, that looks like I'm rounding in the CCU, which is the critical care unit for cardiac patients. And we're seeing patients with, cardiogenic shock, people with pericardial effusions and tamponade, people after, a massive MI, that kind of stuff. And then when I'm done rounding in the morning in the CCU, I'm doing heart failure consults all over the hospital. And that also is a mix of cardio-oncology and general heart failure. So what I like about my job actually is it's never the same, week to week, or sometimes even day to day. I have weeks where I'm primarily outpatient. I have weeks that I'm all inpatient, and I have weeks that I'm mixed.
Yeah. For the procedure heavy person who's looking for a career, looking for a specialty, how much are procedures involved in your day to day?
I think so. For me, I personally don't do procedures. It was something that I decided a long time ago wasn't what floated my boat. However, I will tell you that a lot of heart failure practitioners do procedures. They do many procedures. They do a lot of their own right heart catheterizations. People at transplant centers are doing their own endomyocardial biopsies. So I think the nice thing about heart failure is that you can have the opportunity to either do a ton of stuff, or you really don't have to do very much of it at all. You can be a structural person who also has a mix of heart failure, and you can be doing that kind of stuff. I don't do any of that stuff. I do more of I like to think I'm the intellectual capacity behind all of this stuff, but a lot of heart failure colleagues of mine do a lot of procedures. So I think it's a nice niche because you could do one or the other. You don't have to do both.
So I talk a lot about the Sherlock Holmesing of a career, of a specialty. How many of your patients are coming to you just bread and butter diagnoses, and you're there for treatment and management, versus they're coming to you with symptoms and you have to figure out what's going on?
I think that the difference between being a heart failure doctor and being a general cardiologist is just that. Usually by the time someone makes it to my office, it's because either an internist has had a really hard time managing and they need my expertise, or more likely a general cardiologist or multiple general cardiologists have tried, for many, many years and did a good job for a while. And then the patient's just getting sicker. And so they kind of need someone like me to provide a second opinion, or sometimes even a third opinion. And honestly, oftentimes when a heart failure patient makes it to my office, it's because they're very sick, and they're, whoever is referring the patient is looking for me to take a look and see if there's any other options. Is there an option for a pump? Is there an option for a transplant? Is it really someone who's just too sick for any of that and needs a palliative care referral or something like that? Sometimes it's, the bread and butter stuff. So usually that's like the patients that I meet myself in the hospital, and then they become my long-term patients. But usually the referrals in the office are people that have already had a first pass or even a second or third pass with a general cardiologist, I would say. Yeah.
Talk about a lot of students. When I read their personal statements, they are very kind of, rose, whatever you call that, rose covered glasses, whatever that phrase is. They love the positive side of medicine, saving lives, all that fun stuff. Every once in a while, a student will say, I know I can't save everyone, right? That death is a part of this. For you as a cardiologist, as an advanced heart failure cardiologist, cardio-oncologist, I'm sure that potentially you may have your fair share of patients who don't make it, whether it's just cancer comes back or their heart gives out. How do you handle that? How do you separate that as a parent, a spouse, human? How do you not bring that home, and how do you take care of yourself in those times?
Yeah, it's a hard question to answer. I know I do it, and I know I've honed that skill over the years. I think I'm a lot better at it now than I was when I started, 10, 15 years ago, but it's never, ever, ever easy to lose a patient. I've been to more funerals than you want to know, because almost always I actually go to the patient's funerals, because if you think about it, when you're a heart failure cardiologist or a cardio-oncologist, many of these patients, I've known them for years. I know their family, their spouses, their grandchildren. I know their entire life story, and they know mine. Yeah. And you really become almost like extended family of theirs, because you're seeing them, so frequently, and you're really through all the trials and tribulations with them. And my kids will tell you that I don't not bring it home. I often bring it home. I mean, if I lose a patient, I'm really, really upset about it for a very long time, especially if it's someone that I've known for a long time and I've sort of seen them, through their ups and downs. It's very, very hard. That being said, I actually think that I take this not lightly at all, that I feel very privileged to be a part of that patient's journey, more so than really many of their other doctors. And I have had many a patient where I feel very satisfied at the end, that I'm confident that if they hadn't met me or one of my colleagues, that their lifespan would have been a lot shorter, and that we were able to provide them with way more life and way more years than they would have had, had they not had the benefit of our expertise. And I think there is something to be said for that, because it's a real huge privilege to do that for someone. And the last thing I will say is, we do our fair share of, I actually joke in my next life, I'm either going to be a kidney doctor, because we do so much kidney medicine in heart failure, or I'm going to be a palliative care doctor, because we do so much of our own palliative care managing and palliative care conversations. And I think that there really is something to be said for giving a person the opportunity to die the way they want to die, if we can't make them live the way they want to live. And, and that's not something that I appreciated when I first started, but certainly over the years, I feel like that is probably one of the most profound things that we do in heart failure.
Yeah, it's interesting, the whole right to die movement that a few states have passed legislation on. It's interesting, and again, I think for students coming up through the ranks, they, depending on their religion and wherever they were born, their culture, they're very adamant against it. And I always, like, in the back of my mind, I'm like, just wait, just wait until you
take care of a patient who can't breathe. And
yeah, it's terrible. It's terrible. And my family's going through it now. My mom's husband was just given 3 to 6 months with his own cancer diagnosis, and we'll see. Right now he's doing okay. He has cancer, you can tell. But luckily he's doing well, and we'll see where that takes him. Colorado is a right to die state. So yeah. I don't actually, now that I think about it, I don't know if we've had that conversation, if I've had that with my mom and with him. So maybe after we hang up.
It's always tough. But again, I think that in our line of work, as long as we're confident that we have done everything we possibly can, we've overturned every stone that could be unturned, and we've tried everything and we're not successful, then again, there is something to be said for, for helping a patient transition and sort of like the transition to palliative care and hospice and all of that. It's never easy. It's like a crappy conversation to have, but it's important. And I don't think everyone does it well. So I think that it's important to have that skill also if you're going to go into a field like this.
Yeah, it's so important. So very important. So what do you like the most about your specialty?
I think that I really do like so much. There's so much not great in medicine these days, but I always say at the end of the day, I love my job so much that I cannot imagine doing anything else besides what I chose to do. I think what I love the most is the relationship over time that I'm able to have with a lot of my patients, like I described before. I have patients that I have known for 12 or 15 years, and I have been through the gamut with them. A lot of them I met when they were literally about to die, and they're alive still 12 or 15 years later. And so just sort of like following those people over time and getting to know them and the relationship you have with those patients. And you know what, Ryan, because I'm back and forth between the office and the hospital, and obviously, particularly for our heart failure patients that get hospitalized, unfortunately, quite a bit, to see and, like to show the resonancists that when you walk in to the room and see one of your own patients and they're like their face lights up because they see that it's you and not just some random, cardiologist walking into the room. I've had residents say that to me before, like, wow, that patient really, really loves you and really respects you. That's what keeps me going. I think what I love the most. And that's why even when you have the crappiest day and you're writing notes until 11 o'clock at night and you're fighting with insurance companies and all of that, at the end of the day, that's what I love the most about medicine.
Yeah. So let me ask you, because there are plenty of physicians out there who have very longitudinal care of patients, and those patients don't light up when that physician walks into the room. What do you do to build that relationship, to make that patient light up? What is so special about Dr. Bloom?
I don't know.
That
You'd have to ask my patients.
We have to give it to these 112 students watching right now so that they can do the same in the future. Do you think that's just your personality, just how you were raised? You seem like a very cheerful person.
Yeah, I think it's all of it. I think a lot of it is my personality. I think anyone will tell you that, if I can connect with you, then all of a sudden I'm an open book and, that's it. But I think that it's just, I think that the patients can appreciate that I love what I do. And I think I am genuine about that. And I am open and honest about that. And I think that's probably what builds the rapport. Look, I've had patients over the years where for whatever reason we didn't connect, but I would say largely, I feel like I make this sort of indescribable connection with my patients from very, very early on in the relationship, and that lasts. And I think that also, gets you places with the relationship too. And what I mean by that is, if a patient respects you and a patient loves to see you, they're more likely to take their medicines. They're more likely to show up to their visits. They're less likely to be hospitalized. They're more likely to call when there's something wrong rather than thinking, oh, I won't bother her. My patients know that they should bother me. I want to be bothered by it. I want to be able to help them. But that, again, that's a relationship that builds over time and trust and honesty. I think it's a lot of it is personality. And I think in medicine in general, right, we go into things that sort of drive us based on our personality. And I think to go into heart failure medicine or cardio-oncology, I mean, think of it. It's like people joke with me, that's the two most depressing things in medicine, heart failure and cancer. Yeah. And I love it. I mean, what does that say about my personality? But I love longitudinal care and I love these deep connections. And I think almost like the sicker the patient is, the more of a deep connection they are looking for in a cardiologist. And so I think that's why it works.
Yeah. That's amazing. And I love the passion. I think I wish I saw more of it among physicians, but they're still out there. Super passionate physicians are still out there. And
they're still out there.
You're an example.
Otherwise, you can't do it. I mean, nobody would last in this field anymore unless you really deeply loved what you did. Right, Ryan?
Exactly.
I mean, it's not the same as it was. A lot of the people that are retiring now will tell you it's not, but yet I feel like I love so much what I do.
Yeah. And when I talk to students about the change, and I don't practice anymore, I let my wife do the practicing and I get to sit behind a microphone most days, is what I typically tell students is when they come and they're like, the doctor I shadowed is like, why are you going into this? This is miserable. Don't go into medicine, pick anything else. And my general response is healthcare has changed. Everything changes in this world. Who's paying for the healthcare, who's running healthcare, the suits in the hospitals, all of that stuff. What doesn't change, and exactly kind of what you brought up, is that moment that you walk into the room and you close the door. That human to human connection will hopefully never change in healthcare. Maybe there's a device that we wave in front of the patient between us, but other than that,
I don't care what anyone says. Nothing replaces that.
Correct.
Nothing replaces that connection. Like when I walk into the door, I could have been having the crappiest morning or the crappiest day or whatever it is. And I walk in and I close the door and I have this connection with a patient, and nothing in the world, could top that. Nothing.
Yeah, 1,000%. So before we jump in, I know there's some cases. I would love to bring a potential real world case to see if the heart failure community has been talking about this picture circulating of King Charles and his swollen fingers. Have you seen this picture? No. And are the heart failure doctors talking about it? No. So there's a picture of him like 2 weeks ago standing up, and his fingers are so swollen, like not a picture of good health. And so I was just wondering if it's like, oh yeah, that's classic. He's got some heart failure going on. So.
Well, I mean, maybe if you told me his legs were swollen or you could see his jugular vein up, then I'd say, okay, he's got to get an echo and he needs Michelle Bloom. I don't know. Finger swelling can be a little non-specific. I mean, you certainly can get anasarco, which means that you have swelling everywhere in the body. Yeah. But usually we don't see, as the first presentation of heart failure, just isolated swollen hands. So maybe he has something else. Maybe he has rheumatoid arthritis. I don't know.
Maybe. Yeah, maybe. Okay. Just wondering if that's going around. There are some questions. Heather just asked a quick question. Did you take any gap years? I didn't see any gap years in your journey there.
I didn't take any gap years. I was one of those people. I didn't tell you this story, but I was literally one of these people. In third grade, there was a career day.
Yeah.
And they asked people to make a poster of what they wanted to do. And I actually made a poster. And this was, by the way, this was in the 80s. So it was not where you could easily cut out these letters. I cut out the letters anesthesiologist, which, as you can imagine, took a really long time.
Yeah.
And I made this poster. So I was wrong on the specialty, but I definitely was dead on accurate that I knew I was going to be a doctor, even from the time I was 6 or 7 or 8 years old. So there was no way I was taking any gap years because I knew where I was going and I knew I had to get
on a mission. Yeah.
Yeah. I was a girl on a mission.
It's funny when you say you were cutting out letters, all I can picture is a ransom note. Those random ransom notes with the magazine letters cut out.
By the way, I still have the poster in my basement.
That's amazing. That is phenomenal. All right. I would love to jump into these cases.
I don't know if we'll have time to go through all of them, but I actually just wanted to go through them quickly just because I wanted to show the students like kind of the broad range of what we see in cardio-oncology, less kind of for content and more just to give you a sense of how cool it is that we see such different stuff. So I guess I'll try to quickly go through these. Okay. So I put 3 in, and again, you stop me if we don't have time for all 3, but the first one is a 44-year-old man. He was a former active smoker, but recently quit. He was actually seen in an urgent care facility because of dizziness, and they sent him into the ER because he had a rapid heart rate noted on an EKG in the urgent care. They found him to have this atrial tachycardia, also with some non-sustained ventricular tachycardia, which is an abnormal rhythm. And when they admitted him to the hospital, they found that he had a non-STEMI with a small troponin peak and an elevated NT-BNP, which is a marker we use, for elevation and filling pressures. Okay. You're going to advance, right?
Yeah.
Okay. So he didn't have any past medical history. His parents were still alive. We always ask them about sudden cardiac death in the family. He didn't have any of that. He wasn't a drinker. I told you about the smoking, and he works as a mason. So I'm actually shocked that this is playing, because usually when I do these cases, there is a technical problem. And again, I mean, suffice it to say, because I know you guys haven't looked at a lot of echoes, when I tell you the ejection fraction, which is essentially the pumping function of the heart, was very low. It was estimated at 42%, where normal we usually say is around 65. And hopefully what the students can appreciate is there's something here that shouldn't be here. And what it was is a large echo density, what looks like a mass on the right side of the heart. And so when you see this, you start thinking, is this a malignancy? Is this a clot? Is there something else here?
Yeah. And are you, hold on, why can I not? Oh no, I can't use any of the fun, cool, features to highlight something. Oh, well.
Well, I'm actually amazed it's playing at all. And then this is actually when we inject some contrast to sort of give a differentiation between the regular muscle and this mass. And you can see that this very, very large mass is kind of waving in the right ventricle of the patient's heart.
Yeah. Wow.
Not good. And then this I wanted to show you, we also wound up doing a cardiac MRI, which is sometimes a better test to sort of characterize what this thing is, because on an echo, you can't always tell if it's a clot or a tumor. So we did this cardiac MRI, and you can see where I circled in red that this was the mass on the right, inside of the right ventricle, right next to the septum.
Wow.
So just keep going forward. So we did a cardiac catheterization, mostly because when we see that the ejection fraction was low, we needed to make sure that the guy didn't have coronary artery disease as a reason for the low pumping function of the heart. And suffice it to say here, this was essentially a normal cardiac catheterization. It was not an arterial issue. So for whatever reason, the ejection fraction was low, but his arteries were clean. So, we treated him with beta blockers. He was transferred to our cardiac care unit. The arrhythmia guys got involved, and ultimately had to have a biopsy because we needed to figure out what this mass was. And it wound up to be this anaplastic large B-cell lymphoma. So he wound up being transferred to the oncology service because he needed right away to start chemotherapy. Okay, so you could go forward. So he started some arrhythmia therapy at the same time. Our team got involved because obviously the ejection fraction was low, but also we needed to communicate with oncology, because normally in a situation like this, they would start him on something called anthracyclines, which are sort of like the gold standard for this type of lymphoma. But we told them absolutely they could not, because the ejection fraction was already low. And also he had an arrhythmia. So he was at a very high risk, and we didn't want them to do anything that would further compromise his heart function. So we had this sort of interdisciplinary conversation between us and the oncologist. And what they did was they picked a different regimen called gemcitabine, dexamethasone, and cisplatin, so that they wouldn't use something that was directly toxic to the heart. Yeah. And he was briefly rehospitalized. He had some CAT scans. You can go forward. Because I just want to give you the highlights.
I want to know, I'll stop sharing here real quick. How common is it for the cardiologist to go to the oncologist going, hey, I found cancer for you? Well,
that's actually, it's funny you should say that, because it doesn't usually happen that way, but it does more than you would think.
Really? Wow.
Yep. Where we're doing an echocardiogram or a cardiac MRI for something else, and we find something and it winds up to be some type of malignancy. So it's not super common, but it's not uncommon.
Wow.
And this, I wanted to show you guys, not because I'm reading it to you, but this is what my notes look like. So that's why it takes me till 10 o'clock to write my notes. Yeah. So this was the first time I saw him in the office after he got out. And really, like, what we do is we put a lot of thought into sort of giving the history and giving the background of why we're doing what we're doing, because we find that this is just helpful to all the other doctors involved in the plan. So suffice it to say, this is what most of my notes look like. So what happened was we got him on all of this therapy for his heart failure, and we got him on arrhythmia therapy, and simultaneously he was getting the chemotherapy. And you can see that when we repeated the echocardiogram a couple of months later, not only was the pumping function a tad bit better, but more importantly, you could see that you no longer see that mass.
Yeah.
So the chemotherapy worked to, reduce the size of the mass where you no longer can see it. So you can keep going.
With the ejection fraction not improved a ton, is that just where the mass was? The heart is damaged beyond repair at that point?
Well, we're going to get to it.
Okay. Okay.
So, and I mean, it's an important question, but that's where people like heart failure doctors come in handy.
Yeah.
So he wound up getting the chemotherapy. He completed a few cycles, his follow-up PET scan, which is what the oncologists use to sort of figure out if there's malignancy elsewhere. There was no more uptake, and it was a much more favorable PET scan. And they started planning him for a stem cell transplant. Okay, so you can go forward, and then here is his repeat echocardiogram a month and a half later. And here, his ejection fraction wound up getting significantly better.
Yeah.
So the size of the ventricle was a little bit better. The ejection fraction was better, and the mass was still gone. You can see on the right side that there was no more mass. So again, suffice it to say, it was just a multidisciplinary way to approach this patient, right? Because if he had just seen oncology, then they would have done their thing, but they wouldn't have been able to sort of address the real issue with the heart. And if it were just us, we would have addressed the heart, but we would have had no inkling of a clue what to do with, the chemotherapy, and particularly whether or not there would be success in using a non-anthracycline based regimen. So really I think the beauty of a cardio-oncology specialty is that you can have this multidisciplinary approach where both specialties can do what they do best and talk with each other along the way. And that way you get better outcomes for the patient.
Yeah. So a question that came in, how long did chemo take? So this patient came in.
It was a few months. I think he came in July, and all of this was settled and he was ready to go through stem cell transplant by September.
Okay. And then was he still on chemo at that point, or he was done at that point?
He was done. And what they were doing was they were teeing him up for a stem cell transplant. I didn't put the end of the stuff, but I can tell you because I still follow him. He's actually doing great. He actually got a stem cell transplant. The ejection fraction is still normal. We still have him on all of his cardiac meds, and he's cancer-free, a couple years later.
Yeah. Amazing. So question from Jessica, would you be able to see abnormalities like this via blood work, right? Potentially with lymphoma, seeing some abnormalities.
Yeah, potentially. But I think really the oncologist will tell you that imaging is necessary, and then ultimately tissue biopsy is necessary to make the diagnosis. So you can see subtle abnormalities on the blood work, but with him, really, I think what clinched the diagnosis was, seeing it on an echo and then being able to biopsy him.
Yeah. Very, very interesting.
Yeah, but that's just sort of like that's like a classic why do you need a cardio-oncologist kind of case.
Yeah. No, that's a perfect example.
So this one I'm going to go through with you because it didn't have as good of an outcome, but I'm showing it because I think it's important to kind of know that this is also why you need cardio-oncology involved. This patient did not have us involved. I met her after it was already too late, but she was very dear to me. 37, she had 2 kids. She had breast cancer a couple years before we met her, and she actually presented in cardiogenic shock with biventricular heart failure. So she had breast cancer in 2010. And she was treated with adriamycin and cyclophosphamide with a total dose of 240 mg per meter squared, which, trust me when I tell you, is a pretty standard breast cancer regimen, particularly for certain types of breast cancer, and a pretty standard dosing. Not a ton of anthracyclines, but a reasonable dose nevertheless. And she was actually found to be in remission from her breast cancer the last time she saw her oncologist.
Okay.
We can go forward. So past medical history, other than the breast cancer, was really kind of non-contributory. She smoked for a few years, but nothing major, and no family history of any cardiomyopathy or anything like that. That would suggest another diagnosis.
I'm surprised to hear a cardio-oncologist say smoked, but nothing major. Like one cigarette, terrible.
She smoked a half a pack a day for 13 years. So not that it's good, but I don't think that I guess I meant to say that you wouldn't think that this person had coronary artery disease or something like that, that she didn't have other major risk factors for cardiac disease.
Yeah.
And her EKG was grossly abnormal. She had bigeminy, which meant that every other beat was a ventricular beat, which is never something that you want to see on an EKG in a person that's in cardiogenic shock.
Yeah.
Okay. And then here, I don't know, will these play?
Yeah.
So I think you don't have to be a person who reads echoes regularly to see that this ventricle is just not moving.
It ain't moving.
It's not moving. Yeah. It should be really contracting, but instead it's just not moving. And what she had was all 4 chambers, so both atria and both ventricles were severely dilated and severely hypokinetic. She was in trouble.
Wow. I don't know if I've ever seen an echo like that.
Yep. So she was in trouble, and then just go forward a couple of slides. So also we did an MRI and her ejection fraction
Why
was
does it keep doing
15%.
that?
I don't know, better you have technical issues than me, because this is my everyday life. I have technical issues.
All right.
You could go forward. So she had a catheterization where we did her right heart cath hemodynamics, and, without going through in detail, trust me when I tell you, she was essentially in cardiogenic shock. She had very poor end organ perfusion. Her filling pressures were way, way up, and her cardiac index was 1.2.
Yeah.
We
and so
generally think of
cardiogenic shock for students listening. It's shock, right? Your body's in
Yep.
shock, but it's not because you're bleeding out. It's not from an infection. It's the cardiogenic is like this. The heart is causing this.
The heart is not sustaining perfusion to the rest of the body. The heart is so weak and not, giving you forward flow enough to actually perfuse your organs with enough oxygenated blood.
Wow.
So she was admitted with decompensated heart failure. We wound up having to put an LVAD, which is a left ventricular assist device in. And she had, multiple complications, one after another, and ultimately, unfortunately, wound up dying. And she was 37. And I put this case in, Ryan, because this is a patient where it turned out that her cardiomyopathy was because of her chemo. And she survived a breast cancer at 37 years old, was free in remission of breast cancer, and wound up dying of essentially cardiogenic shock from a bad heart secondary to chemotherapy. And I put it in because this is the other reason why you want to get a cardio-oncologist or a cardiologist with any type of expertise in this involved early, when she's getting the chemo, or even a lot of times before the chemo, to make sure that she's optimized and to follow over time and do imaging and make sure nothing's wrong so that you prevent this from happening.
So here's where I get a little bit like mad at the world, at technology. We have the technology to prevent this. The hope of EMRs, and doctors may not like this, is when that oncologist is putting in the diagnosis and checking all of those boxes, that the EMR says, hey, this drug shows evidence of heart failure later on. You need to, if you want to get paid, go get a cardiologist on board on the team.
Yeah.
Why is that not a thing at this point in our life?
I don't know why it's not a thing. I mean, I will tell you that our group specifically has worked really hard, just at our institution level. So for example, now when a patient is admitted to the hospital to the leukemia and lymphoma service, and the plan is to give them anthracycline chemotherapy, we actually worked with the EMR people at Stony Brook to put in a power plan whereby the oncology people can very easily check off to do a pre-chemotherapy echo and pre-chemotherapy biomarkers and check lipids and also even very easily check off to have a cardiology consult, so that a cardiologist sees that patient very early in the hospitalization, because we felt like from a quality improvement standpoint, at the very least, if you make it easier for the oncology team, to do that stuff, then they will. I mean, in fairness, a person comes in with acute leukemia, or a person has a bad breast cancer, they don't have a ton of time to be doing other stuff. They need to start the chemo right away because it's obviously an emergency and the patient will die otherwise.
Correct.
But I do think it is important to raise awareness, not only for oncologists, but also for internists and any other people that are taking care of these patients, that we really should be involved early.
Yeah. I am a huge tech nerd, right? And I don't know how much of me you looked into, but I have a software company now that I run, trying to help the Premed course easier for students. So there's a lot of random crap that happens in the Premed world. I'm like, we have technology, we can fix this.
Yeah.
And so it makes me mad that this kind of stuff isn't around, because even if this patient had to have the medications she had to save her life from her breast cancer, and we knew that this was going to be a complication, Well, guess what? She could get in on a transplant list earlier. She could have had an LVAD implanted earlier to prevent all of these other complications.
More important than all of that, if you get us involved before the chemo or at the beginning, then what we do is we do surveillance imaging, and we see them in the office, and we screen for symptoms and the development of any stuff, so that it's, we catch it really early, and we can intervene with heart failure medications early, or catch it when it's still asymptomatic. And then they have a much better outcome than if they develop heart failure before we get involved. So that's what we spend a lot of time educating, our colleagues about.
Yeah. That one makes me mad. Anyway.
Yeah, it was a sad case.
Yeah. Samia asked, was she made aware of the possible side effects beforehand? We don't know.
I mean, right? I don't know. I will say the oncologists are pretty good about making patients aware of this stuff. I mean, they have a laundry list of things that they have to go through with patients, because believe me, the cardiac toxicity is not the only toxicity. They get neurotoxicity, they get infections, there's a lot of bleeding, there's a lot of other things. And again, it's not to say that they shouldn't be using these agents. Sometimes they have to use these agents. I think that the real crux of the issue is that if you are watching these people closely and doing the proper surveillance and testing, you can prevent a lot of toxicity down the line.
Yeah. I'll open it up to questions from students. If you guys have questions, go ahead and raise your hand. We can unmute you. You can ask some good questions. Only good questions allowed.
Only good ones.
Only good ones. So you talked about what you love the most. What do you dislike about the field outside of charting and losing a patient? Well, we'll take those two away.
Yeah. Well, considering right now I'm studying for my boards for the third time.
Yeah.
And I've been practicing for 15 years, and I am a full-time practicing doctor and a mom of 3 boys.
Yeah.
I don't think it's great that in our specialty, we still have to be taking tests, like years and years out. So I'm kind of bitter about that.
And
so I don't love that.
Paying $1,500, $2,000.
And you have to pay for this pain.
It never ends. Everyone's complaining about the MCAT. Just wait till your board exams, friends. Right.
So I'm rounding with last week I was in the CCU rounding with the students and the residents, and one of them is studying for her step 1. And I said, you think it's over now? Yeah.
Oh, it never ends. Never
ends.
Taylor, go ahead and unmute.
Hi, can you hear me?
Yep.
Mm-hmm.
Okay, great. So your specialty is really interesting. I don't want to take away from that at all. But as you said earlier, no one talks about the aspect of how do you manage family life and all of these other things that you want to do if you want to pursue medicine. And I love that you touched on that. But how did you manage to do things like going on maternity leave or dealing with all these things while you were in residency and fellowship programs that expect so much of your time?
Yeah. I don't know. Ryan will have to have me on for a whole hour just to talk about that. Because it really is, it's actually something that is so important and so not talked about, which I told you at the beginning is why I mentor a ton of students, and I actively talk to them about it, because I think it's important upfront to know what you want out of your life and know that you have to sometimes make choices where, something is going to get sacrificed, but at the expense of something else that you feel is really important. And I think that it's really hard, and there's not one right answer for any given person. For me, I made a lot of sacrifices, in my career, because I knew that it was important to me to have a family, and vice versa. I miss a lot of stuff with my kids. I'm not at every soccer game. I'm not at every, event at school where it's bring your mom to school day. Because I'm in the CCU sometimes, but my kids know that I'm there for the important stuff. And when I'm there, I try to really be present. And when I'm in the hospital, I try to really be present. And I'll tell you guys what I often tell to the people that I mentor, which is when I first started, and this is pathetic, but when I first started, I used to actually feel at the end of the day, which did I do worse? Was I a worse doctor today, or was I worse mom today? And I made myself change that narrative. And so now at the end of every day, maybe I'm not perfect at both. I mean, I don't think there's a such thing at being perfect at both, but I remind myself that I'm doing the best I can at home, and I'm doing the best I can for my patients at work, and I'm doing the best I can for the people I mentor. And that's the best I'm going to do. And nobody is perfect. So if you expect to be perfect, you're always going to be disappointed. So you have to just change the narrative.
Yeah, you have to. And most of the you're not doing well, I'm failing, most of that is coming from yourself. It's not like people, and sometimes maybe you don't get the promotion, whatever, and your kids are like, they'll guilt trip you sometimes. Yeah. I love talking about this because I get the question a lot about work-life balance. I don't believe in work-life balance personally.
There's no such thing.
I think there are different seasons of life. Obviously, during your training, you were much more involved in the hospital and you needed to lean on other people, and you weren't around as much. Now that your kids are older, you're out of training. Maybe there are things that you are requesting your colleagues to lean on a little bit more. And closed captioning. That's cool. I've never seen that before. And so I think every day is different in terms of what your priorities are that day. And it's never a balance. So you're focused on one or the other. Right. It's hard. It's hard. And
it's different for everybody. It looks, that's a career looks different for everybody, a man, a woman, depending on your age, depending on your, your other social situation. There's not one right answer. And honestly, I think a lot of it just a lot of us just make it up as we go along. That's the best you can do.
Just make it up and just be nice to yourself and give yourself grace to go. It's okay. It's okay.
I mean, I think my kids will tell you at the end of the day, and I'm an okay mom. I don't know if they think I'm a fantastic mom, but I think that, they're pretty well adjusted. So we must have done something right.
Yes. Well, based on how you described how your patients light up when you walk in the room, I'm sure your kids are doing just fine. So
you can show the last slide. Show them the last slide, Ryan.
Oh yes. Let's go
to the end, because I made sure to put that in because I feel like at least I have something to show for all of this craziness, right?
I love it. Let me see. Play from current slide. Share screen. All right, and let's go to the end. There we go.
So that's baby 1, 2, and 3. So the biggest one I had when I was a resident, the middle one I had when I was a heart failure fellow, and the little one I had when I had just started, a couple years after I started my first job as an attending.
Wow.
And now I'm the proud mom of a high schooler, a middle schooler, and an elementary schooler.
Yeah. Bless you.
And I always say that my day at work is easier than my day at home.
1,000%. Night times in our house are miserable. Yeah. I would rather be rounding all day in the hospital than try to do bedtime.
Yeah.
Dr. Michelle Bloom, thank you so much for spending an afternoon with us. No interruptions from the 8-year-old or the dogs.
There you go.
You can thank them.
That's a successful day.
Huge. Take the wins when they come. I appreciate your time, your wisdom, and I would love to have you on potentially on my podcast, my just regular old podcast to talk about that. Work-life balance.
I love talking about it, not because I have the solution, but because I feel like we all live it and nobody talks about it.
Nobody talks about it, right? And you could blame it on social media. We all present our best selves, but we've been doing that forever. You walk outside after having an argument with a spouse and your neighbor's like, "Hey, how you doing?" You're like, "I'm great."
Right.
Nobody goes,
Fantastic.
"I'm terrible."
No problems here.
Yes, no problems. All right, everyone. Thanks for hanging out. And again, Dr. Bloom, thank you so much for coming and hanging out.
Thank you so much for having me, and good luck, everybody. You picked an awesome, awesome career.